Welcome back to another episode of our stories, Wisdom from Great Minds. I'm your host, Sasha Chupa, and today we have the privilege of speaking with someone whose work has made a profound impact in the world of hematology and sickle cell disease, Dr. Julie Kanter. Dr. Kanter is a physician, researcher, and advocate who has dedicated her career to advancing care for individuals living with sickle cell disease. As a leading voice in the field, she's been instrumental in pushing for better treatments, increasing awareness, and ensuring that patients receive the care they deserve. But beyond her clinical expertise, Dr. Kanter is also a woman in medicine, a leader and a mentor who has navigated the challenges of this field with passion and determination. Today, we'll explore her journey, what inspired her, the lessons she's learned along the way, and the wisdom she has to share about leadership, resilience, and the future of sickle cell research. So let's dive in. Welcome, Dr. Kanter.
Thank you. Thank you for that introduction.
Of course, thank you for being here today. I wanted to start out with your personal journey and your inspiration. So to begin, I want to ask you, what inspired you to pursue a career in hematology and what drew you specifically to sickle cell disease?
It's kind of a long story. I'll make it the short version. When I was growing up, my brother actually had a genetic disease or has a genetic disease, but we didn't know it for a long time. And he went through a lot of trials and tribulations in terms of getting to the right doctor. And in hindsight, of course, more than when I was, 13, can tell you that no one ever stepped back and looked at the whole person that he was. And this was now, God, I'm old, right? So this was over 40 years ago when we're just starting to really understand the complexities of genetic syndromes. Long story short, he finally got to a physician in Boston. We're from New Orleans, so it took an incredible amount of advocacy on my parents' part to get him to someone that could actually help. And they right away knew that he had DiGeorge syndrome. This is not remotely related to sickle cell disease, of course, but that's really why I wanted to go into medicine. And I actually initially thought I would go into physical therapy because, especially when I was younger, the person that I saw that had the greatest impact on his life was this amazing physical therapist that he had. And to me, as a young child, his physical therapist made him a real boy, if you will, really made it so that he could do all the things that all the other little boys did and really impacted me. And so that was my original thought. From there, I wanted to do sports medicine, and I went into medicine thinking I would do orthopedics and sports medicine, and quickly realized that I didn't like to operate, and that I also really didn't like that I'd spend more time with people when they were asleep than awake. I really wanted to know my patients. And I'm an athlete and I love athletics, but I didn't want to also not operate and depend on surgeons that did. So that kind of took that out. And in an even more confusing story, I ended up on an extra clinical rotation in my first year when most people weren't doing clinical rotations, where I got to observe in a pediatric hematology oncology clinic. And it was through friends of a friend, which how things sometimes work out. And it was what I needed at the time because I was feeling disillusioned with not seeing anything but textbooks and, gross anatomy and all those things. And I fell in love with the area of hematology oncology because I loved getting to know my patients and I loved getting to be with them long term. I didn't like the ER or the ICU where they were quick visits. I always wanted to be part of their whole story, not just a portion of it. So that's what I kind of did heading into residency. I decided I wanted to do pediatrics initially and then hem-onc. And then when I got to hematology oncology, I thought I was going to do late effects for similar reasons. I wanted to be part of the whole story. And I didn't, even though I saw a lot of sickle cell disease in New Orleans, I hadn't seen as much in my residency in Colorado. Well, when I was there, there were two particular patients that changed my mind, that changed my course. And the general concept that when I was a resident, again, a while ago, and a fellow, we didn't have enough options for people with sickle cell disease. We had hydroxyurea, we had transplant, we had transfusions. There weren't really any new therapies in development. And here I was with my pediatric cancer patients. And while I didn't always have another alternative, it took me a long time to run out of options, even when they relapsed. And we just didn't have that, what I considered somewhat of a luxury in sickle cell disease. And then the two patients who changed my mind, one was a young woman. She was in her teens and she walked in and she had shortness of breath and cough and everyone said, oh, it must be acute chest. It must be acute chest. And she was very tachycardic. And I said, I really think this is a pulmonary embolism. And the physician I worked with at the time said, no, we just don't see that in kids. And I said, I really think this is a pulmonary embolism. And sure enough, it was a pulmonary embolism. And she was one of the first people that made me realize that people weren't thinking big enough. They were so focused on the red blood cell. They weren't remembering what was happening throughout the rest of the body. The second was a young man who I'd seen many times. He was unfortunately in the hospital very frequently. And one day he walked into clinic and he looked a whole lot worse than usual. And within minutes, he was coding in my clinic, and he didn't survive. He was only 18. And I mean, I still think about, what did I do wrong? How could I have made that better? Or better yet, how could I have prevented that from ever happening? And those two people really combined, those two patients that I think of all the time, made me realize that I could make more of a difference in sickle cell disease than I was ever going to make in oncology. And they're phenomenal scientists and researchers in oncology, so don't get me wrong, but the work was more incremental in oncology, and I wanted to move faster, I guess, and do more work. And I had a lot of questions that I felt people weren't answering, like hypercoagulability and inflammation. And in fact, I was studying P-selectin, which is an endothelial inflammatory marker, among other things. And when I considered, could this be something we should look at in sickle cell disease, my physician that I worked with, who was the sickle cell director at that time, said, no, we're not doing that work. Some X or X may do it, but we're not going to do it. But I'm your fellow, and I want to look at this, and this is my project. And he said, no, I just don't think it's that important. And of course, lo and behold, several years later, not only did we recognize its importance, but that we now have a drug that targets the blocking of P-selectin to decrease vaso-occlusive crises. So all those things together, it was that sickle cell disease needed more help. It needed someone to take a step back and look at the bigger picture of people. And as I've sort of aged in the career, what my next step was, we need to grow up with these kids. So we need to not think of this as a pediatric and then an adult condition. We need to think of this as a chronic lifespan condition. So that was where I went with that. And here I am now.
Again, that's amazing. That's one of the reasons that I admire your work and I admire you. It kind of brings up to this next idea here that, especially being from the South and what's happening right now in the country, we're talking about these inequities, right? And you're in a field where that, again, the disparities, this gap is very high. So I guess the best way to approach this, I wanted to ask, or what are some of the challenges you felt that you have faced in a field that has such high disparities, and how have you managed with, as you mentioned, you were studying something that even as you were their fellow, they didn't want to let you study. How do you manage kind of being resilient in the face of something with that high of a gap?
You learn and you get better over time. I didn't always do it well, and I don't always do it well now. I think there's a lot of questions within those questions. I think being a woman in science is still hard. I had issues recently in my own institution, and it was someone who was male and who was not only not being respectful, but was being truly disrespectful. And while we had issues, I figured I can manage this. We can move forward. Well, then he became very disrespectful to another physician, female physician in my clinic, who's on my team. And that was where I drew the line. And so you have to know what battles to fight. And for me, that battle involves, you can step on my feelings, but you can't step on my colleagues, who's my responsibility. Mm-hmm. Now that's many, many years and many learnings, let's say, along the way. I think there is still a struggle for women in medicine and certainly in leadership. And it is a bigger struggle when you're fighting for a population that no one fights for. And those two things together are unbelievably difficult. And we, in the last few years, myself, Sophie Landskron, Wally Smith, and had worked very closely, now Payal Desai, and previously a wonderful physician from Yale, we had all worked together on building an ASH-sponsored sickle cell disease workshop on building sickle cell centers. And it's probably one of my favorite things I've gotten to do in my career, because most of us had built these centers sort of with duct tape and prayer and pulled pieces together, and we didn't go into medicine with business plans, so we didn't even know how to write a business plan. In fact, the first time I needed to justify a position and someone said, okay, we'll write a business plan, I had to Google it. And when we looked out at what some of our first groups of our attendees to this workshop, one of the things that struck us was that it was almost all young women who were in these leadership positions, taking care of a patient population that had been tossed away, and everyone had the same struggles. And the most cathartic part of this was hearing not only that everyone had the same struggles, but that in some ways it seemed unintentional that these young women were put in a position to not succeed, mm-hmm. and that we needed to build up a way to help them succeed. So, and you'll have to edit and go back and forth because this is answering your question in different order. I still don't think I have the best answer for how do you take care of a population that has been consistently disrespected. Mm-hmm. In that, because we live in hematology oncology, we sickle cell tend to live in hematology oncology, and our management, our care, our everything is very different than it is in oncology. Mm-hmm. And of course, we are constantly compared, or when I ask for a certain position, a nurse coordinator, well, oncology doesn't need that position, why do you need it? Mm-hmm. And it's very hard to explain without what I've been told is coming off as condescending, to others that our clinical paradigm's just different. Individuals with sickle cell disease have faced unbelievable challenges. That is very different than the world of oncology. And I think because we're often in that same bucket with oncology, it's harder to recognize. So what I did was went to find somewhat similar groups, like who could I learn from? Cystic fibrosis provides a lot of good roadmaps, and they've done a phenomenal job improving outcomes, and they're really a group that we look up to. But they've never faced the hardships that people with sickle cell disease have in terms of stigma, in terms of disrespect. But they still have built an excellent roadmap about caring for people who live with a chronic condition that they are born with and that they're going to grow into an adulthood with. So we learned something from them. And then even more now, I have learned from the HIV population. It's a very, very comparable patient population in that these are individuals who have also faced unbelievable stigma and disrespect and are constantly disrespected even today. And there is a kinship there that I think we can learn from each other on. What has worked for your population that can work for mine? And so when I talk to the C-suite, the CEOs, the CMOs, I really try to get them to understand our population by comparing the most comparable population. Because I think people, when they think sickle cell disease, they think blood, they think cancer. And, one day you didn't have cancer and then you did, and hopefully you'll be cured and then you don't again. And for the most part, that's not true in sickle cell. It's a chronic lifespan condition. And so you need to so congenital HIV is one of the most comparable populations that can help people understand. And that's what I think is most important, is how do you help people understand other groups of people that they have no ability to put themselves in their shoes. I spend a lot of time teaching, put yourself in someone's shoes, meet your patient where they are. And that can be really challenging. And I've worked with people who get very frustrated. I'll give you my favorite current young example, or my favorite example in young people. I call my patients who are anywhere from 18 to about 30 teenagers, because many of them still act like teenagers. And there's a lot of reasons for that. And some of them is that their maturity gets delayed by having a chronic condition. But in this day and age, how do most teenagers communicate? Text. How do most people in my generation communicate? Phone calls. So we have a very tough time reaching our young adults if all you do is try to call them. And I have a lot of people I work with that feel like it should be up to the patient. It should be the patient's responsibility to change how they act. They need to answer the phone because we want them to answer the phone, as opposed to the other way around. How do we make the system change to help the patients? So that's what I've really had to do, is help people understand that system changes are where we're going to get our biggest bang for our buck. And how do we help others kind of understand where someone else comes from to make sure that they understand why we want to make those changes. You asked about resiliency. Resiliency is hard. And I think what I have learned through the years is recognizing when it's hard, not sending an email when you're angry. It's taken me at least 10 years to get that right. I still teach others, but I have a coach now. I have my husband to read my emails ahead of time. I think about things that I shouldn't email. And I think the same way in some ways that I do about my patients, in that if I'm emailing someone who I know doesn't agree with me, okay, how can I meet them where they are, at a place of compromise as opposed to a place of anger? I think the other thing is finding like-minded allies is really helpful, because one of the things we learned, so in between about 2017 and 2021, even before COVID, we lost about a fifth of our sickle cell workforce, physicians. We didn't lose them, they just left academia.
Oh, yeah.
They went to private practice, they went to industry. Why? Because it's hard. It's a patient population that still lacks resources, lacks attention, despite everything. And that makes it very challenging. And sometimes we can't fix everything, and we want to offer more and there's not more to offer. And that's hard. And sometimes we just want to get people into clinic and they live 2 hours away, and that's hard. And I think when you're under-resourced to help do these things, when you don't have the Leukemia and Lymphoma Society driving people to clinic, or you're not at St. Jude's where they can get people to clinic easily, that gets really frustrating. And we recognize this among many of the deficiencies. We also recognized that as part of this workshop that we had been building, we needed to define what a sickle cell center was. Because if I went to a CEO and said, I really need a social worker, they would say, why? Why do you need that? You can use oncology social worker when you need them, which of course my patients are never prioritized. So we got together, and many of us got together and said, what is a sickle cell center? What should it be? What do we want it to be? What does the optimal center look like? We did what's called a Delphi study, and put 2 papers together, one for adults and one for pediatrics, to start answering that question. And now people were armed. They had a paper. paper that said, if I want to be a center, these are all the pieces that I need. And we created the National Alliance of Sickle Cell Centers. And in creating the alliance, we did it for a number of reasons. But one of the most, I think, reasons that warms my heart is watching everybody have a place to talk about the things they face. Because if you have allies, if you have people who understand what you're dealing with, it makes us all stronger together. And that really has helped my own resilience in what I'm doing. And so I think there's lots of different avenues to go, but certainly finding your friends and allies is one of them.
Thank you. This actually segues into what I want to talk about next is, I guess recently there's been these two new treatments for sickle cell disease. And now I know as a medical student, I had friends that they were talking about it. And it seems like the problem with sickle cell disease is now over, right? There's these two new cures. The cure to sickle cell disease has now happened. It's like happily ever after. What changes have you noticed since then? And yeah, what are your thoughts on what's been happening since these two?
So, first of all, it's not over, and by no means are we happily ever after. There are two new gene therapies that have been developed for sickle cell disease. And at this point, the word we use in the sickle cell community is transformative. They are not curative. Why do I say that? Well, I mean, among other reasons, it just hasn't been long enough. So if I want to tell someone that I don't think they're ever going to get a stroke because of their sickle cell disease, I need a lot of time to be able to answer that. I need to follow people for a long time before I can feel confident in saying this transformation, this change, this transplant has prevented this from ever happening. We just don't know that yet. And because this is a community that's been so beat up over the years, sometimes lied to, sometimes not treated fairly, I want to be very careful with my words, and I want to be careful all the time. So I always call it a transformative therapy, and I do. It is amazing and phenomenal. I use all of those words. It's just not quite curative, and there's a lot of other biological reasons for that. The other thing is it's still not easy. It still takes 6 months to a year of someone's life, and in fact, when I talk about it, because they hear it as, oh, it's a one-time treatment, it's easy. That's what the patients think when they come to me. And I say, that's only sort of true. It's a one-time treatment that takes about a year. And I say, okay, if you give me that year, I'll give you the rest of your life. Like you are giving me your time so that I can give you everything else. But some people can't take work off for a year or not be home with their children for a month at a time while they're in the hospital. And for children who are looking at these potential treatments, can their provider, can their mom, their dad be in a hospital all that time? And it's not a year straightforward. It's bits and pieces along the way, but it's a very intensive treatment. And there's a lot of people who aren't comfortable with that amount of time, and it's still new, right? So there's a lot of unknowns. Is it going to last their whole lives? We hope so, but we don't know. Some of the other gene therapies, the example I use most often is one of the hemophilia therapies. They thought it was forever, and at 5 years, it started not working as well. And so we hope that this will be durable. And at least the first one out of the block, which is the Bluebird or Lyfgenia therapy, we've now seen 10 years of data. It looks very durable, but we still have a lot of answers that we don't know yet. I say all that to say that it is amazing and transformative, but it's not the be-all end-all. And there are people who are never going to want to go through this huge therapy. The complications still include infertility and include the risk of death. We had one of our first patients ever die due to the chemotherapy as part of one of the clinical trials, and this has been published and announced. And it was that this chemotherapy that we use to make room in the bone marrow has a very rare but real chance of causing permanent lung toxicity. And so that brave young woman who wanted to do this therapy unfortunately didn't survive. And we know that early, not recently, but early in the days of starting this therapy, we had 2 patients who had leukemia as a result of the procedure, not from the gene therapy itself, but the whole procedure. And again, I don't expect that's going to happen again, but I can't say it never will, because if you took 100 people who got an autologous, a transplant from their own cells, 1% will get leukemia. So 1 in every 100, because you're altering their bone marrow, even though they're getting their own marrow back. So these are all still high risk, high reward, but high risk treatments. And so we still need novel therapeutics that don't involve that kind of risk. And we know also that something like hydroxyurea, which has been around for a while, I have people who are on hydroxyurea who are 60, 65, 70, and they're doing very well. When you ask them, they would not go back and do a treatment like this, because to them it was better to know sickle cell than it was to know the unknown of what may happen. The other thing is they're expensive. And a lot of people want to understand why they're so expensive. The main reason is that they are very expensive to make, and the clinical trials are unbelievably expensive to run. So some of the expense is the recoup of that cost for those companies. Some of it is that it is just a complicated science, and complicated science is expensive. And I think that until we can get these prices somewhere reasonable, it's going to significantly limit our access. And a lot of the investor community says, why is this taking so long? Like, these have been approved since the end of 2023. Why did no one receive them in 2024? I think one person did. And the answer is very complicated, and it's teaching me even more business of medicine that I wasn't sure I wanted to know, that you have to understand how the health system works and who gains in the health system. We know the patients gain in this. I don't think anybody questions that. But if you're going to spend $2 or $3 million, how does that affect the entirety of the health system on that one patient? And so until we can answer these questions in an economic way, it's going to be a challenge. And I think we're trying to figure that out as fast as we can.
Thank you. And again, this helps because a lot of people, again, believe that these therapies were a one answer and no one needs the help anymore when there's still a lot more work to be done. And because I'm catering to your time here, and I said this was a 30-minute interview, this show is about wisdom and philosophies here. So I wanted to ask, if you were to talk to your younger self and you had one piece of wisdom to tell yourself, what would that be, especially in keeping your identity through this path? What piece of wisdom would you tell yourself, your younger self?
It's a great question. A lot of people, I think, look at women who are leaders and you hear words like you're intimidating or you're derogatory or you're condescending. And I've heard all of those. And it's always said as here's how you need to fix yourself. And that's hurtful, right? Like, that's hurtful when the gentleman next to you is a leader and he's a strong leader. And I could say the same thing and be mean or intimidating. I've been told to add more smiles. I've been told to cry more. Kid you not? Things that you just, I know very strong male leaders. I could not imagine their chair sitting them down and saying it'd be better if you showed more emotion. Maybe cry when you're sad. So I would say a couple of things. One, I would probably take a few more deep breaths along the way. I would start from a point of trying to be as understanding as possible and truly not sending an email when I'm angry. If there's anything I've learned, it's that. But I would also say that it's important to stay true to you. So even today, I think people will say I'm abrasive. That's another word I get. Or I'm just condescending. And what I try to do now is when I introduce myself to people, I try to tell them about my personality so that they know that I'm not the warmest, fuzziest person in the room. But my job is to take care of people in the best way possible with the most humanity possible, to give them the most respect possible. And that's what I want from people around me. And that sometimes I forget to thank you for doing your daily job. But I'm not unhappy, right? I think you're doing a fabulous job. And I do think we all need to tell each other that we're doing a fabulous job more. But I do also warn people, like, if you're worried, please come ask me. Because I'm running around doing way too many things at one time. And sometimes I don't remember, as I should, to remind you that you're doing a great job. Or to stop and pat everyone on the back, even though I think that they're doing a great job. So I found it really helpful to tell people that and to kind of just let them know up front. The other part is I am one of the most direct people that I know. It's also something that tends to get me in trouble. Now, I appreciate it when other people are direct. I don't want you to tell me something and then whisper about me. I want you to tell me what I need to do so I can do it. And to me, it's also the shortest line between two dots is that direct pathway, right? But I've tried to start to, again, meet people where they are. Is this the way they're going to take in the information? How can I change not who I am, but how I put it in a way that is better for someone else? And so I think I would say stick to who you are. You don't need to change you. But sometimes we do need to change how we do things to make ourselves more approachable and more understandable. And that shouldn't be taken to heart as in, I'm not a good person or I'm not nice enough, but rather I need to make sure that people see me for who I really am, not for the person who's just got too many things on their to-do list.
Yeah. And you may think people may have thought abrasive. I think fierce. And that was one of the first things that, again, like called out when I met you. I kind of was like that woman, that's a fierce leader there. And
thank you.
Appreciate that. And on top of that, I think something that you've been mentioning that you would tell your younger self about your identity and staying yourself is you do a great job of locating the humanity of people, right? So the entire time that we've been talking, you've treated me like a human being. It takes that to also treat the population that you're taking care of, these sickle cell patients. You're focusing on the humanity of people. It doesn't matter that you don't need a smile on your face all the time. You just need to treat people like humans, which Dr. Kanter, for as long as I've known you, in the short timing that I've known you, there's never been a moment where there's been a sense of abrasiveness, whether you be direct or whatnot, you have treated me and the whole population you take care of with a beautiful humanity at the top. So very much appreciated. Thank you for even taking the time to meet with me and tell your story on this show. It is
My pleasure.
powerful and important. And with that, I'm going to wrap up the show and just say thank you again for being here today. And
Well, thank you for having me. Thank you for letting me add my voice to your show.
I'm going to stop.